Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 4 of the Neurology chapter. We're going to start by talking about herniation. This is a serious consequence of very high intracranial pressure or mass effect that results from a traumatic brain injury, tumor, or stroke. The skull is a closed cavity that cannot expand to accommodate increasing ICP, so the brain shifts around structures such as the falx cerebri, tentorium cerebelli, and foramen magnum in an attempt to decompress. This places extreme pressure on delicate neural structures, which often leads to coma and death. Herniated patients typically exhibit the following two abnormal postures: decorticate posturing and decerebrate posturing. Decorticate posturing, as a result of lesions above the red nucleus in the midbrain, a patient presents with arms flexed and hands clenched and bent inward over the chest and the legs extended, with feet inward. The former is caused by red nucleus disinhibition, which favors motor neurons to the flexor muscles of the upper extremities. The latter is caused by lateral corticospinal tract disruption, which normally supplies motor neurons to the flexor muscles of the lower spinal cord. Decerebrate posturing. This is a more serious lesion involving damage below the red nucleus, usually a brainstem lesion. Patients present rigid with clenched teeth, arched head back, and arms, elbows, and legs extended. Herniation can be categorized into two major classes: supratentorial and infratentorial, depending on whether the lesion is above or below the tentorium cerebelli, consisting of subtypes according to which direction the brain moves in response to increasing pressure. Supratentorial, starting with uncle. Downward transtentorial herniation of the innermost part of the temporal lobe, the uncus, through the tentorium cerebelli, dura that separates the cerebellum from the cerebrum, which can be associated with the following. 1. Kernahan's notch. Uncal herniation causes an indentation of the contralateral cerebral peduncle or crus, which contains descending corticospinal fibers, leading to ipsilateral hemiparesis at the site of herniation because it is above the decussation, crossing of the fibers. This is often termed a false localizing sign because the herniation creates injury on the opposite side of the brain. 2. Compression of the ipsilateral posterior cerebral artery leads to contralateral homonymous hemianopsia. 3. Blown pupil. This is one of the earliest signs of uncal herniation. As the third cranial nerve is compressed, parasympathetic neurons surrounding the nerve are affected first, resulting in unopposed sympathetic drive and pupillary dilatation, or mydriasis. As compression progresses, the innermost motor part of cranial nerve 3 is affected, leading to ptosis and eye deviation, which is down and out. Remember that cranial nerve 3 innervates the levator palpebrae. 4. Durate hemorrhages are parenchymal bleeds in the pons and midbrain caused by tearing and bleeding in the small paramedian arteries of the basilar artery, leading to abnormal posturing, coma, and death. Central herniation. Downward transtentorial herniation of both parts of the cerebral hemispheres through a notch in the tentorium cerebelli. Durate hemorrhages can also result from this. Cingulate or subfalcine herniation. This is the most common type of herniation, in which the innermost part of the frontal lobe herniates under the falx cerebri. The frontal lobe can then press on the anterior cerebral artery and mimic symptoms of anterior cerebral artery ischemia or stroke. Transcalvarial herniation. The brain squeezes through a fracture or surgical site. Infratentorial herniations. Upward cerebellar. As a result of increasing posterior fossa pressure, the cerebellum can move up. Downward cerebellar or tonsillar herniation. Coning of the cerebellar tonsils downward through the foramen magnum. The cerebellar tonsils can compress the brainstem and cause the medullary respiratory centers to cease to function, leading to apnea or abnormal breathing. As noted, this can also occur in Arnold-Chiari malformation. Now let's move on to the spinal cord, beginning with motor neuron signs. Differentiating between upper and lower motor neurons can assist in localizing the damage or lesion along the motor tracts. Upper motor neuron signs include hyperreflexia and increased tone with a positive Babinski. Lower motor neuron signs include hyporeflexia and decreased tone with atrophy and fasciculations. Now we're going to discuss spinal cord lesions, beginning with Brown-Séquard syndrome, which is hemisection of the spinal cord leading to the following findings. Below the lesion level, there are ipsilateral upper motor neuron signs. There are ipsilateral dorsal column signs, such as loss of tactile sensation, vibration sense, and proprioception. Contralateral spinothalamic signs, pain and temperature loss, that begin a few spinal cord levels below the lesion. Recall that the spinothalamic tract travels rostrally for a few segmental levels before crossing in the anterior white commissure of the spinal cord. At the level of the lesion, there is ipsilateral loss of all sensation and lower motor neuron signs. Poliomyelitis. This is spread through the fecal-oral route. The poliovirus replicates in the oropharynx and small intestine before spreading hematogenously to the CNS, where it leads to destruction of anterior horn cells and to lower motor neuron signs. Tabes dorsalis. Degeneration of the dorsal columns of the spinal cord as a result of tertiary syphilis. Patients can present with a variety of symptoms such as weakness, paresthesias, a tabetic gait, loss of coordination, impaired response to light, progressive joint degeneration, absence of deep tendon reflexes, and tabetic ocular crisis. Treatment often consists of intravenous penicillin with pain control and physical therapy. We're going to take a moment to go through each of the pieces of tabes dorsalis in a bit more detail. The paresthesias can be a shooting, lightning, burning, or pricking pain. A tabetic gait is a high-stepping gait with the foot striking the ground. The impaired response to light is the Argyll-Robertson pupil, which will be discussed later during eye pathology. The progressive joint degeneration is a Charcot joint caused by neuropathic osteoarthropathy, leading to destruction, resorption, deformity, ulceration, and ultimately potentially infection. This type of joint can also be caused by diabetic peripheral neuropathy. A positive Romberg test is a test that tests for proprioceptive sensory loss. The tabetic ocular crisis is a sudden, intense ocular pain with lacrimation and photophobia, known as a Pell crisis. Next up is Horner syndrome. It's the ipsilateral presentation of facial rubor or flushing, anhidrosis, the absence of facial sweating, meiosis or pupillary constriction, as well as ptosis. There's a mnemonic for this, RAMP, for rubor, anhidrosis, meiosis, and ptosis. Horner syndrome results from lesions of the sympathetic outflow tract on the affected side. Many diseases can be the cause, including apical lung tumors, Brown-Séquard syndrome, lateral medullary syndrome, cluster migraine headache, trauma, thoracic aortic aneurysm, multiple sclerosis, late-stage syringomyelia, and carotid artery dissection. Infection. Let's start with meningitis. This is inflammation of the meninges, which houses CSF. It is the protective membrane surrounding the brain and spinal cord. Patients typically present complaining of headache and neck stiffness associated with fever, altered level of consciousness, photophobia, and photophobia. In meningococcal meningitis caused by Neisseria meningitidis, a rapidly spreading petechial rash that is non-blanching can be seen on the trunk, extremities, mucous membranes, and conjunctiva. On examination, patients generally have signs of meningismus, which includes nuchal rigidity, or the inability to flex the neck passively, the Kernig knee sign, which is knee pain with passive extension, and the Brzezinski neck sign. Neck flexion causes involuntary flexion of the knee and hip. Ultimately, diagnosis is made by lumbar puncture, which can differentiate the various causes of meningitis, ranging from bacterial to aseptic or non-bacterial causes, such as viral and fungal, by looking at specific factors within the CSF. CSF also can be sent for more specialized tests to look for certain causes, such as syphilis with a VDRL, Cryptococcus with India Inc., enterovirus or herpes simplex virus with viral polymerase chain reaction assays, and neurosyphilis, Lyme disease, or coccidioides, as with the use of titers. Initial treatment should include IV fluid resuscitation if hypotension or shock are present. Because bacterial meningitis can be life-threatening, antibiotics should be immediately started if there is a high clinical suspicion prior to obtaining blood work, lumbar puncture, or blood cultures. Adjuvant treatment with corticosteroids should also be given to reduce overall inflammation, leading to reduced mortality, hearing loss, and neurologic sequelae, such as learning and behavioral disabilities. Viral meningitis typically requires supportive therapy alone, such as fluid and analgesics, because of the benign course. However, if a patient is relatively young and presents with some behavioral changes or a seizure, suspect HSV, which has a predilection for affecting the temporal lobes. The CSF in HSV encephalitis also typically has an elevated red blood cell count. In this case, the addition of acyclovir is warranted. Despite ideal management of meningitis, complications can arise, such as deafness, epilepsy, seizures, hydrocephalus, disseminated intravascular coagulation, Waterhouse-Friderichsen syndrome, which is adrenal hemorrhage with hypotension and hyperkalemia, as well as sepsis, leading to death. Encephalitis. Encephalitis is an acute inflammation of the brain that presents as fever, headache, confusion, drowsiness, and fatigue with a viral or bacterial cause. Some common viruses to keep in mind are herpes simplex, rabies virus, poliovirus, and West Nile virus. Some common bacterial causes include syphilis, Lyme disease, and pathogens that cause meningitis. Abscess. A brain abscess is a collection of infected material formed from distant infectious sources or local spread, such as from meningitis, mastoiditis, dental abscess, otitis, or sinusitis. Patients will have increased intracranial pressure and focal neurologic signs caused by the space-occupying lesion. A right-to-left shunt is also a risk factor. As a result, a patient will appear very ill with a fever, headache, and focal neurologic findings. Diagnosis is established by CT, which typically will show a ring-enhancing lesion. Lumbar puncture is contraindicated because of the risk of herniation. Treatment ultimately consists of a combination of antibiotics and surgical drainage of the abscess, depending on the location. Viral infections. West Nile virus is caused by flaviviridae, usually affecting humans through infected mosquitoes. At first, a patient may be asymptomatic, but can eventually develop a fever and encephalitis. Progressive multifocal leukoencephalopathy is a disease caused by the John Cunningham virus, or JC virus, leading to quickly progressive demyelination of oligodendrocytes. Normally, JCV is kept under control by the immune system. It can cause disease only when the immune system has been severely weakened, especially in AIDS patients, or by immune-modulating therapies, such as rituximab or natalizumab. Parasitic infections. Toxoplasmosis is a parasitic disease caused by Toxoplasma gondii that affects humans through contaminated cat feces or ingestion of meats infected with cysts. The disease spectrum includes encephalitis, chorioretinitis, cutaneous lesions, and congenital lesions. Taenia solium, also known as pork tapeworm, is the most common tapeworm infection of the brain worldwide. It causes neurocysticercosis, which is a leading cause of seizures and epilepsy in the developing world. This disease develops from eating raw or undercooked pork or from the ingestion of tapeworm eggs via the fecal-oral route. The eggs hatch in the intestine and pass through the intestine wall to migrate preferentially toward the brain and muscles, where they form cysts that can remain dormant for years. However, once active, they may cause a local inflammatory reaction, causing myalgias or seizures. Treatment with albendazole and steroids is only warranted if a patient is symptomatic, such as having seizures. Otherwise, if one coincidentally finds an asymptomatic patient with neurocysticercosis on CT, no treatment is needed. Prion disease. A prion is an infectious misfolded protein that accounts for transmissible spongiform encephalopathies, such as bovine spongiform encephalopathy or mad cow disease in cows, and Creutzfeldt-Jakob disease, or CJD. Kuru, fatal familial insomnia, and Gertzmann-Straussler-Schenker syndrome in humans. Prions can arise from sporadic mutation or genetic transmission, or they can be acquired. Once acquired, these misfolded proteins act as a template to induce pre-existing, properly folded proteins in neural tissue to convert to misfolded ones, which continue the same process in a chain reaction cycle that exponentially grows the population of misfolded proteins. Patients typically present with rapid neurologic deterioration, starting with personality and psychiatric changes and ataxia, which leads to dementia and loss of the ability to speak. Findings on exam generally include myoclonus, or involuntary jerking movements, with the EEG showing periodic sharp wave complexes. Once acquired, the end result is universally fatal, and patients are generally given supportive and comfort care. Strict sterilization in denaturing the protein's tertiary structure is key in preventing further transmission. The mainstay of sterilization is a combination of heat, pressure, and chemical cleansers. That's the end of this section of the book. In the next, we'll pick up with demyelinating diseases.